Good morning and welcome back to Open School. Today, I am going to discuss with you the general examination that is relevant to respiratory system. Respiratory system is divided into upper respiratory tract and lower respiratory tract. You should have a proper history, a general examination, and then only go for the systemic examination. Before starting the examination, you should wash your hands, introduce yourself, confirm the patient's name and identification by at least looking into the ID number or home address. Briefly explain what you are going to do in patient's own language and get their consent. Then only start examination. And it is a female patient, always should have a female bystander or a chaperone with you in order to avoid later complaints. What should be the position in which patient should be examined? Ideally, the patient should be in the sitting posture so that you can examine, inspect from front, back and side. And if the patient cannot sit in the lying down position or 45 degrees, you can use and turn the patient to side so that you can examine the whole of the chest. Do always a general inspection, preferably from standing from the foot end of the patient. Look at what is the approximate age of the patient, because some diseases like malignancy, COPD are more common in elderly. Look for features of cyanosis and breathlessness. Look for the tripod position, which is characteristically seen in patients with COPD. They will also have pursed breathing. They will be sitting with their elbows on their thighs or on the table like this. The tripod position should be looked for. Carefully look for medical equipments attached to the patient. Observe if there is any cough. If the cough is there, the character of the cough, including the bovine cough, about which you have discussed earlier, audible wheezes, whether there is any stridor is there, whether the patient looks pale, or features of edema or cachexia are there, because cachexia is a feature that is seen in malignancy or in chronic disease like tuberculosis. All these should be the general observation. As mentioned earlier, look for medical equipments like oxygen delivery devices, sputum port, other medical equipments like monitors. If vital sign charts are there, look at the charts and the fluid charts and the prescription charts also you can look for, especially when you are doing a follow-up in IP patients. When you are presenting, you usually say there is no anemia, cyanosis, clubbing, pallor, lymphadenopathy. That is the usual format we say. But examination is a little different. Always start with hands, because most patients expect that you examine the hands first. Palpate the hands or give a shake hand to the patient. Many observations can be made. In emphysema, the hands are usually warm. Cold, sweaty hands are seen in anxiety. So, start with the hands. The most important thing in the hands, looking for clubbing, but always look for other things like color, the nicotine staining, any skin changes or joint problems, and look especially for hand wasting small muscles, which is in bronchiolic carcinoma, that is the pancreas tumor. As mentioned, looking for clubbing is very important. Examine the hands tangentially. Look for the lower bones angle. Then look for fluctuations of the nail bed and do the Shamrose window test. See whether the diamond shaped space is visible. If there is a parrot beaking or drumstick appearance is there, press the long bones, squeeze like this and see whether the patient has got pain or they winces. The term hypertrophic pulmonary osteoarthropathy, that is joint problems, can occur. And the characteristic finding on Radiography is periosteal, subperiosteal newborn formation that can be seen in the plain X-ray. The pulmonary causes for clubbing are, most important is lung cancer, suppurative lung disease like bronchitis, lung abscess. The interstitial lung disease is very important, clubbing with cyanosis, in cystic fibrosis. Tuberculosis is a very rare cause. Only when there is a extensive fibrocavity you get clubbing. Emphysema you can rarely get clubbing. Now ask the patient to keep the hand outstretched and look for any fine tremor is there. Many patients with COPD, bronchial asthma are on salbutamol or beta agonists and they can have tremor. So looking for fine tremor. At the same time, you ask the patient to keep the hands outstretched like this and cock it up. This is for looking for evidence of flapping tremor. So flapping tremor, look for in both hands. Ask the patient to maintain the outstretched hands in the cock up position. What will happen? Patient will have inability to maintain the posture, sustained posture. So hand goes like this. There is something called negative myoclonus. This is seen in patients with the carbon dioxide retention, that is evidence of type 2 respiratory failure seen in COPD patients. Now it is time to examine the pulse. Examine minimum 1 minute. The important findings to look for is a bounding pulse, that is in patient COPD. You can get pulses paradoxes in severe asthma and COPD. Details will be discussed in session on pulse. At this time you count the respiratory rate. Respiratory rate is counted pretending that you are counting the pulse rate. Keep your hands on the pulse and observe the chest movement. Never keep the hands on the chest of the patient or the abdomen, because patient will become conscious about the breathing. The pattern will change. If you want, you can keep the hands of the patient on the abdomen or the patient so that you can see the movement of the hands also. So the most important thing is pretend that you are counting without the patient aware of that you are counting the pulse rate. Count for at least 1 minute. Look at the rate. More than 20 you call it as tachypnea, less than 12 you call it as bradypnea. Look for the patterns of breathing, which we will discuss in another session. In the era of technology, we have got multiparameters which will show the respiratory rate, pulse, BP and SpO2. It is always preferable to check that, or at least you should occasionally check the respiratory rate physically also. So along with respiratory rate, you look for the SpO2 because it is the fifth vital sign. So use those industry can see the video on pulse oximetry. In the respiratory rate, you will look for abnormalities. You have already described. 12 to 20 is the normal. More than 20 is tachypnea. Less than 12 you can call it as bradypnea. And various abnormalities in the rhythm. At least remember the Kussmaul's breathing, that is a rapid deep breathing, that is seen in acidosis. And also think about the Kaim-Stokes breathing. It's a type of periodic breathing. There is waxing and waning of respiratory rate. So the rate increases, depth increases, then there is a pause. Again it starts. So remember these abnormalities in the respiratory pattern. When you are observing the rate, they should also be looked for. Now check the blood pressure, because vitals, the vital signs are pulse, respiratory rate, BP, temperature, and the fifth one being load is the SpO2. record the blood pressure. By using the BP apparatus, we can look for the pulses paradoxes. So once you examine the hands, now we look for the face. Whether patient has got any features of vena cava compression, like dilated veins. Patient had taken steroids. Many patients may be on steroids, so they may have puffiness of face or some Cushingoid appearance. Many of them can be polycythemic. Look for these things in the face. The most important abnormality that you look for is the Horner syndrome. So in Horner syndrome, what you get, there is a partial ptosis and miosis. So here in the picture on the left side, you can see that there is a partial ptosis, and this can occur in apical tumors, what we call as the Pangos tumor, due to involvement of the cervical sympathetics. So any respiratory system patient, while examining the hand, look for small muscle wasting, CAT1, and look for Horner syndrome. This picture shows the sympathetics. Those interested can look into the video on Horner syndrome for more details to identify which order neurons are involved in various types of Horner syndrome. So once you examine the face, look at the oral cavity. Candidiasis. In immunosuppression, significant candidiasis can occur in diabetes. HIV is an important condition, should look for. In addition to candidiasis, you can get oral hairy leukoplakia. So hygiene of the mouth is important. Patient can develop aspiration pneumonia. So that is the importance of examining the mouth and oral cavity. During examination of the face, we can complete the examination of the upper respiratory tract. You can look at the nostrils, the flaring up of LNAC, any tenderness of the paranasal sinuses, deflected nasal septum should also be looked for. Once you have completed the face, now it is time to examine the neck. The neck we are interested in. One is the jugular venous pulsations, second is the trachea, the thyroid, and the lymph nodes. These are the minimum 4 things you should examine in the neck. Details of the jugular venous pressure and measurement is discussed along with the cardiovascular system. Here we are interested to see whether the neck veins are engorged, whether it is pulsatile. In non-pulsatile, engorged veins are characteristic of superior vena cava compression. That is what we are primarily interested. If the jugular venous pressure is elevated in a COPD patient, this can be due to corporal nail. Right heart failure, that is occurring in patients with respiratory disease due to development of pulmonary arterial hypertension that later leads on to right heart failure. When the neck veins are engorged, look at the legs and see whether there is any edema. Because in right heart failure, the first sign to appear is edema and the last sign to disappear is also edema. So elevated JAP without pleural edema is not due to cardiac failure. That's the point you should keep in mind. Hope this point is clear. And in patients with early heart failure, we can go for the hepatojugular reflex, press on the abdomen and see whether the sustained rise of jugular pulsations occurs. And in case of retrosternal thyroid, we can look for the Pemberton sign. It is asking the patient to elevate the hands like this and see whether there is a congestion of the face occurs. That is the Pemberton sign. We have mentioned the respiratory cause of raised JVP. First and foremost, think about superior vena cava compression, where you get a non-pulsatile JVP and the upper level of JVP cannot be visible. Congestive heart failure that we have discussed. Now it is time to look for the lymph nodes. Lymph nodes are examined usually from the back. All the lymph nodes should be examined properly. We are mainly interested in the supraclavicular lymph nodes. The right supraclavicular lymph node is enlarged in supradiaphragmatic conditions, and the left supraclavicular lymph node, otherwise called the Virchow's node, is characteristic of infradiaphragmatic malignancy, especially gastric carcinoma. Those interested to know about the Virchow's nodes and the proceed sign are requested to view the video on Virchow's nodes. The lymphatic drainage of lung is important. The whole of right lung and the lower lobe on the left side drains to the right supraclavicular region. So that is why supradiaphragmatic conditions produces enlargement of the right supraclavicular gland. The pleura drains into the axilla. So abnormalities of pleura can produce lymphadenopathy in the axilla. The respiratory cause of lymphadenopathy are 1. Tuberculosis can occur in sarcoidosis and lung cancer with metastasis. We have mentioned about the retrosternal goiter, the Pemberton sign. Patient may come with features suggestive of a superior vena cava compression. Now it is time to look at the skin, whether there are any abnormalities, especially related to tuberculosis, like cyanosis, scars, papillonecrotic tuberculosis, lupus vulgaris, lichen, etc. we can look for. Now it is time to examine the lower respiratory tract, and this will be discussed in detail in the next session. Thank you for the listening. Stay tuned for further videos on respiratory examination. Thank you. Hope this was useful to you.